June 1993, the fast tracking is located within the confines of the Emergency Medicine and Trauma Center. Financial break-even is performed to determine the point where the program generates enough revenue to cover its total variable and fixed costs, both direct and indirect. It means that this break-even analysis was created to solve problem that has total variable and fixed costs, also both direct and indirect.
In methodology, the design was used in the study was retrospective financial and patient data to calculate the financial break-even volume. Also, this study illustrates the use of financial techniques and its flexibility as management tools to maximize cost estimate. In this study, the settings was conducted in emergency emergency medicine or EM, and tertiary center or trauma center at Tertiary Care Midwestern Hospital. And the study population consisted of 446 patients. So in demographical, clinical, and financial data, information was retrieved from the ED computer system and from the hospital department. The hospital's financial database contains all the charge for the fast track visit, include the hospital ED and ancillary charges and professional charges or the physician fees. So the overall collection rate was calculated as the total revenue collected as of December 31, 1993 divided by the net charge. And the charge structures for the fast track was identical to the charge structures for the ED. And in break-even analysis, the total cost of the fast track program has two categories, the variable and the fixed cost. So we all know that when we say variable is changing. So in this study, the variable cost consisted of patient serve, medical supplies, which medical record, and billing clerk. While in fixed cost, has two categories. It is direct and indirect cost. When we say direct, when we say direct cost, it refers to expenses that directly go into the producing goods or providing services. While indirect, it's the expenses that keeps hospital operating, including the hospital costs and equipment depreciation in it. Also, the variable costs were estimated using transitional system, computer decision support system, which combine financial and clinical data. So in addition, the rest of the break-even computation of the fast track program are identical to those of standard business.
The average patient age was 17.6 years, while the patient's reserve pay was 31%. The fast track patients generated to the total gross charge was $68,887.52, and 38% are in the hospital services, 41% for the professional fees, and 21% for ancillary charge. We subtract the contractual allowances, which is $7,003.31. And these patients generated to the $61,884.21 in net charge, with an average of $138.75 per patient, with the range of $14.32 to $673.72. Two patients who underwent head CT had charges in excess of $500. In December 1993, $38,355.85 was collected, and for the overall net collection rate of 62% at 180 days. These are the patients of total percentage collected by payer class. The result of break-even analysis for the FY94 in June 1992, the total fixed cost was $639,929.3, were divided by each patient's contribution of $61.31. Therefore, the needed of fast track are 10,431 annual visits, or an average 869 per month. In June 1993, there was 446 visits, indicating the fast track generated revenues less than the total fixed cost during that month. During FY94, there was 7,032 fast track visits for an average 586 patients per month. In this study, the hospital's collection rate was 62% for the fast track patients. 869 per month. In June 1993, there was 446 visits, indicating that fast track generated revenues less than the total fixed cost during that month. During FY94, there was 7,032 fast track visits for an average 586 patients per month. In this study, the hospital's collection rate was 62% for the fast track patients.
I am going to tackle about limitations and future questions of our research paper. The research paper warrants further study based on the three following grounds. First item, it is about reduction of emergency staff and or fast track expenses. The second one pertains to the ability to treat non-urgent patients at a lower cost on a full-time basis in a fast track environment in comparison to private clinic with limited hours. The final item talks about the impact of healthcare reform, universal healthcare, gatekeeping, and capitation to the financial viability of emergency department and fast-track services. Healthcare reform. It is a maintained process in fundamental change of policies and institutional arrangements of the health sector. Universal healthcare. It is aimed to enhance the functioning and performance of the health sector and ultimately to improve the health status of the entire population. Gatekeeping. It is a requirement to visit a general practitioner to obtain a referral prior to specialist care. Capitation. It is the fixed amount of payment per patient for a prescribed period of time. Aside from limitations and future questions, I am also going to talk about the tables presented for the methodology of our research paper. Table 1. The table enumerates all ailments eligible for fast-track programs. The first group requires the approval of a triage nurse before acquiring the said program. While for the second group, it does not need the consent of a triage nurse, meaning the patient can acquire the fast-track program immediately. Table 2. We can see here how much each service costs and its total. Table 3. This table is showing us the different computations used for standard business entity and fast-track program. Another thing we can notice is that there are more factors involved in fast-track program than the former one.
Good day. I am here to discuss about the discussion part. So it says that the number of patients without care is growing. The money paid by hospital patients is used to pay those who work in the hospital, but not all the financial needs of the hospital depend on self-paid patients. It depends on the ability to exercise control over these factors, which are minimizing operating costs, maximizing program revenues, and maximizing collection rates. In total, the hospital collection rate of fast-track patients is 62%, but this does not include outpatients. However, it does not affect the collection rate. The collection rate, or so-called fast track, is slightly larger than all outpatients. That's all.
Thank you for being here today. I'm Beverly Masbang from the group Grim Arthur, and I am here today to talk to you about the conclusion. This study illustrated that both how a break-even technique can be used to perform sensitivity analysis in a hospital department and to provide a further estimate of the financial viability of a specific unit in the impact that change in the payer class mix would have on the unit's average charge and patient break-even volume. In the ED administration should maintain the fast track program because it is at least partially contributing to the ED overhead. And the method shows that relatively small change in third-party service, coverage, or eligibility requirements can have a large impact on the program's solvency. And that's the end of my presentation.